Welcome and good evening, everyone, to our TIF Talk this evening. We're very excited. We've got a lot of special guests this evening. My name is Andrea Millers, and I'm with Endogastric Solutions. And today we have got three special guests. We've got Dr. Phoenix Nguyen, Dr. Nikolai Bildzukewicz, and a patient of theirs, Jennifer. So welcome all three of you, and thank you for being here this evening. So first off, I want to just give you a little introduction on who everyone is. Dr. Phoenix Nguyen is a board-certified gastroenterologist at St. Jude Medical Center and Mission Hospital. She is nationally recognized expert in the GI field with special clinical interest in GERD reflux, and is one of Southern California's most experienced physicians in using EUS to improve diagnosis and treatment. Her expertise also includes minimally invasive approaches to the treatment of bile duct diseases, fecal incontinence, obesity management, and other advanced procedures. Welcome, Dr. Nguyen. Thank you for being here this evening.
Thank you.
We also have Dr. Nikolai Bildzukewicz, and I think I got that right, Doctor, but he did kindly gave me permission to call him Dr. B tonight to make it a little bit easier. So he is a board certified general surgeon at St. Jude Medical Center who obtained his medical degree from Jefferson Medical College in Philadelphia. After graduation, he was commissioned as a lieutenant in the United States Navy and completed his general surgery internship at the Naval Medical Center, San Diego. He served as a general medical officer and trained at the Naval Aerospace Medical Institute, where he graduated as a Naval Flight Surgeon. After 2 years on active duty as a flight surgeon, he returned to Jefferson to complete his general surgery training, and he completed his fellowship training in minimally invasive bariatric and robotic surgery at the University of California, San Diego. His clinical interests include the diagnosis and treatment of GERD, hernias, and esophageal motility disorders, and advanced laparoscopic hernia repair and advanced techniques for abdominal wall reconstruction. Thank you first and foremost, Dr. B, for your service, and thank you for being here this evening.
Well, thank you for having me.
Fantastic. And lastly, but not least, we have Jennifer, who is Dr. B's and Dr. Nguyen's patient, and she'll be telling her story tonight as well. So thank you, Jennifer, for joining us this evening.
Thank you.
So let's go ahead and get started. We are here today to talk about GERD and the TIF procedure and treatment options for GERD, and also hear about a real patient story. So I'm going to let Dr. Nguyen kick it off. Again, if you have any questions, please feel free to type them in the comment section, and we will do our best to answer all of your questions this evening. One last note is we are doing a giveaway today. We have a TIF tumbler that we are going to give away to a viewer. So if you are on, please comment where you're tuning in from. And at the end of the evening, we will tally up and look at who has responded and commented, and we'll let you know if you have won the tumbler. You will be hearing from one of our colleagues, Lynn McFadden, and she'll be reaching out to you later this week to let you know if you won or not. So thank you again for joining us. And Dr. Nguyen, I'm just going to let you go ahead and take it away.
Okay, I'd like to begin, and thank you for being with us tonight. And I just want to make sure, Andrea, you're seeing our slides, okay?
Sorry, I was on mute. Yes, I can see your slides perfectly.
Okay,
thank you.
Perfect. So gastroesophageal reflux. And what's new in terms of diagnostics and therapy. When we eat and we swallow, the food goes into your esophagus, and I'm just going to jump into what's new and what's the new thinking today for the cause of GERD, or gastroesophageal reflux disease. When the food travels into the esophagus, there's a muscle at the bottom of the esophagus and that's called a sphincter, the lower esophageal sphincter. That is usually closed, and when the food travels down, it'll open up and the food goes through. In patients with GERD, what will happen is this muscle will relax intermittently and food can travel up, causing symptoms of acid reflux into the esophagus. The other mechanism here in green is the diaphragm that separates your chest and your abdomen. And this is thought to be the second sphincter that plays into the mechanism, and why when these mechanisms fail, patients have GERD. So when you talk about the symptoms of GERD, you can have typical symptoms or atypical symptoms, and it goes anywhere from heartburn to regurgitation. The atypical symptoms would include cough, some hoarseness, some people get jaw pain. And then we talk about treating. The treatment spectrum depends on the severity of the condition, and we can do simple things, or we can intervene with medications, or this TIF procedure that we're going to talk about, and then conventional surgery. Medications that are used to suppress the acid that reflux into the esophagus include different types of anti-acid medication. The simple ones include Tums, Maalox, and then the H2 blockers like Zantac, Tagamet, and then the proton pump inhibitors like omeprazole, which is mostly over the counter. So recently, Zantac was taken off the shelf, and a lot of our patients were scrambling around for this anti-acid medication because GERD is such a common condition. So my patients were calling and saying, oh my gosh, the FDA ordered the medication that I really love for heartburn to be taken off the shelf due to risk of cancer and the potential carcinogen that's in the drug. Then I often get calls on patients who take long-term PPI or the proton pump inhibitor that suppresses acid, and there's been various concerns about complications or effects that are related to the use of PPI, and the list goes on, but I think the two main more believable association between PPI and complications include that osteoporosis and PPI use, and also kidney issues. So patients who have osteoporosis that are on long-term PPI for heartburn, we want to look at the indication for the PPI use. There was a recent study coming out from LA, and I think this is important, and it showed that patients on PPI had a higher chance of having COVID compared to those who did not take PPI. And this could be an association, but I think it really makes sense to me because your stomach really needs to be making acid, and now you're suppressing the acid with the drug, the PPI, because you don't want to feel the burn that comes up into the esophagus. So your stomach really needs to have that acid production. That's what God made the situation to occur. So this looks at some diagnostic tests that we do for patients with GERD prior to therapy. And because GERD is associated with cancer and precancer conditions, there's a rise in incidence of esophageal cancer over the past 25 years, and we think it's because of GERD. The initial evaluation for patients coming in with GERD is to kind of make sure that there's no precancer. That's called that Barrett's esophagus before it turns into cancer. So a typical endoscopy would be a little tube that we place inside the esophagus to examine the lining to make sure there's no cancer or precancer. In addition, we want to make sure the esophagus is not inflamed, there's no stricturing or other complications of GERD. On the left is an example of a manometry study looking at the function or the motility of the esophagus, because we want to make sure that the esophagus is functional in pushing the food through, so that if we fix the mechanical problem at the bottom of the esophagus, that food is not going to get stuck as you swallow. This has somewhat been replaced by later technology now we have called EndoFlip. And EndoFlip is a technique that we use to look at the function of the esophagus at the time of endoscopy, so the patient's sleeping and comfortable. This pH testing documents GERD, and the typical way of doing this pH testing is with the Bravo system. So we place a little capsule inside the esophagus, and we have a patient wear a monitor for 4 days. And during those 4 days, we want to see acid reflux. So we're checking for acid that comes up into the esophagus. And here is a typical study of a Bravo study or a pH study documenting GERD. So here is a line drawing the pH of 4, and any red line that dips below the pH of 4 represents a reflux event. So this is in the daytime, this is when the patient's sleeping. So this patient has multiple acid reflux events during the daytime and none during the nighttime. We look at the percentage of time the pH is less than 4, and this meets criteria for the diagnosis of GERD. We also see that this patient has symptom correlation with heartburn. So whenever the patient tells us that there's a symptom, we can correlate it with a reflux event. This is particularly important for atypical symptoms like chest pain. And this patient did have symptom correlation with a reflux event. So that's very helpful in terms of diagnosis. Briefly for therapy, what we have for endoscopic therapy of this condition is called the TIF procedure, and this is a brief overview. The TIF device looks at fixing this mechanical issue that occurs at the bottom of the esophagus to prevent acid reflux. And here at the left, you'll see that the TIF device is placed inside the stomach, and there's a scope that's inside the device. What will happen is we pull the tissue, and tissue is retracted into the device, and we place sutures called fasteners into this area to create what you see here on the right as a 3-centimeter valve and a 270-degree wrap. So this accomplishes the balance that you want. You don't want too much of a wrap that you will have problems swallowing, and you want enough to prevent acid reflux. So this has been shown in studies, many studies, to be effective in preventing acid reflux. So that's the picture and the animation model what TIF looks like. So TIF stands for transoral incisionless fundoplication. So the evidence behind it, there are many, many studies out there. Initial studies looked at comparison between treatment with TIF versus sham, where the patient didn't have the procedure done. Trials looking at TIF versus PPI use alone, and then many different studies with many publications and long-term follow-up showing that TIF is effective at treatment of GERD. So when we looked initially, one measure of how TIF works and outcome, we look at quality of life improvement using a validated score for GERD, and patients at baseline showed improvement in their quality of life at 1 year, 3 years, and 5 years. So this shows that it's effective, and the effectiveness lasts out to 5 years. This shows that we can also eliminate regurgitation. So the anti-acid medications prevent that burn, the symptom of the sour taste, the heartburn, but the anti-acid medication actually doesn't prevent regurgitation. So This looks at prevention or elimination of regurgitation, and symptoms improve up to 5 years. This is after TIF. So I mentioned before, for GERD, you have typical symptoms and you have atypical symptoms. And this shows that TIF also accomplished improvement in atypical symptoms. So that's more subjective. That's how the patient feels. This shows that after TIF, objective measures also improve. That is, we have a baseline pH study with that Bravo system, and this shows that after TIF, the objective measure of pH also improves. So in terms of effectiveness, what we want to look at is heartburn, regurgitation. We looked at quality of life improvement. And just to kind of summarize, the pH studies also can improve. Patients get off their PPI medications in addition to symptom improvement. Meta-analysis or large reviews of the many TIF studies show that over many studies and over 1,200 patients, procedure success is great with very low side effects. More reviews of TIF, I'll skip. This is a patient story, and we'll hear about Jennifer's story as well. But this just really highlights what TIF is able to do. This patient had high-grade dysplasia, which is that Barrett's esophagus with changes that are very close to cancer. The patient was on chronic PPI, and after endoscopic resection or removal of the nodules related to Barrett's and then ablation using radio frequency, over 2 years we were not able to get rid of all of the patient's Barrett's with the high-grade dysplasia, but post hiatal hernia repair and TIF, the patient had complete resolution of the high-grade dysplasia as well as his symptoms. Durability, after, this is immediately post TIF, and you can see the scope, you can see the valve that is created, that 3-centimeter valve, 270-degree wrap, and this is a year post, and you can see that the valve looks fairly similar with one of the fasteners that are remaining. When we looked at TIF alone, we looked at the TIF improvement, patients going off PPI, more objective improvement of esophagitis. So this looks at the many studies with the ability of the procedure to get the patients off their medication. The indications for TIF initially in our earlier series included patients with a smaller hiatal hernia. So the hiatal hernia is, again, part of the stomach back up into the chest above the level of the diaphragm. So for a larger, longer hiatal hernia or wider hiatal hernia, TIF was not possible. This showed in our recent analysis and study that if a patient had a large hiatal hernia, if we combined it with a surgical approach and repair the hernia and TIF, it also worked. And so we'll hear about this from Dr. B in a little bit. But it accomplishes the same result with repair of the hernia in addition to TIF. Adverse events and looking at TIF, very minor symptoms with patients having chest and shoulder pain after the procedure, very few complications as later iterations of the device and as our experience improve. Complication rates are in our earlier series, our last major complications were from 2018. I think this is my last slide, so we'll switch and we'll have Jennifer share with us her story.
Yeah, thank you, Dr. Nguyen. That was a fantastic overview of GERD and the TIF procedure. So thank you. And before we get to Jennifer, there's tons that have come through Facebook. So I'm going to ask a couple of them, and then we can transition and talk and hear Jennifer's story. And then I know a lot of people also have questions about the hiatal hernia. And there's some questions here on the differences between a Nissen fundoplication and the TIF procedure. So we'll get to Dr. B, hopefully can answer that question for us. But before that, and this is probably for both of you, I know Dr. B, you're the surgeon, and Dr. Nguyen, you're a GI, but you both do the TIF procedure, but therefore you can both answer this question or these questions. This question is from Jas. They're asking, can the TIF help with LPR related symptoms such as phlegm in the throat?
Yeah. Nick, we haven't heard from you. Do you want to take that one first?
Yeah, absolutely. So the simple answer is yes, especially patients with LPR. And so that's sort of the atypical symptoms that Dr. Nguyen alluded to in the one study showing significant improvement over 80, close to 90% sustained out to 5 years in atypical symptoms. So specifically in patients that respond to PPIs, those patients tend to do better with any form of anti-reflux surgery in the presence of LPR symptoms, so including TIF.
Fantastic, thank you. And then I assume that would also include anything similar to like symptoms of coughing or coughing after eating as someone part of that LPR category, if you will. There was a question here, can TIF help symptoms of cough after eating?
Yeah, absolutely. I mean, cough is one of those symptoms that can be attributable to many things, and often patients will see pulmonologists and even ENT physicians before coming to us. So usually once we're confident that the cough is due to reflux, and again, especially in the presence of objective findings of reflux, whether it's complications or a positive pH study, then we feel pretty confident that those patients will do well with a repair of a hiatal hernia and a fundoplication, or including TIF.
Fantastic. So this question is interesting from Tony. He's saying, can LPR transition into GERD? Isn't LPR it a symptom of GERD, or maybe you can explain that a little bit? Transitioning to GERD.
I wouldn't describe it quite as a transition. LPR symptoms can be seen in the absence or in the presence of typical GERD symptoms. So as a surgeon, I always feel more confident for a successful outcome when there's a presence of typical symptoms, an abnormal pH study, and PPI responsiveness. But it's not so much a cause and effect or a transition from one to the other per se.
Okay, one last question, and then we'll Dr. Nguyen.
No, I'm sorry, but I think that the symptom correlation on the pH study is also helpful. And like Dr. B said, that if the patient improve on the PPI with the cough symptoms, we like that, because we know that after we treat the GERD, the symptoms may improve. So I tell my patients that if the cough is purely from GERD and we fix the GERD, your cough will likely improve. Now, if the cough is from other things in addition to GERD, whether it be seasonal allergies or postnasal drip, or if you have a combination of other different factors, we fix the GERD, your cough may still be there because there are many other reasons for your cough.
Yeah, it's very good. One last question, and then we're going to transition over to Jennifer to listen to her story. How long does one need to be on a PPI, and why do doctors allow patients to be on PPIs for years?
Dr. B.
You want me to take that?
Yeah.
So when a patient starts PPIs, I usually tell them to give it at least a week to see if it makes a difference in treating their symptoms, and then can usually double the dose after that first week if they've noticed little to no improvement. The pharmaceutical companies design these drugs to generally be taken up to 12 weeks at a time. And then of my experience, most patients will run out of their medication or not refill their prescriptions, and their symptoms may be okay, but I tell my patients that their symptoms are like a roller coaster. They'll have, months where they don't have any worsening, or presence of symptoms, and then they can come back, especially with stressful events in their life or the various things that can cause that LES or that lower esophageal sphincter to relax in terms of what we eat. But then again, on the other hand, I have patients who have taken these drugs for 15 or more years and have done fine. But as Dr. Nguyen showed in her slides, since over the last decade, the FDA came out with several warnings, warning potential side effects with long-term use. And every year it seems like there's a new body system that's affected, showing these large national kind of database, population database studies, a new body system that's affected by these long-term use. So I think there is some concern, on the patient side of long-term use. So, but clinically, I haven't seen any of these, cause and effect relationships.
Okay. Thank you very much.
A little bit of data for patients with LPR needing a longer trial of the PPI. It doesn't work it works a little bit differently for patients with heartburn. You'll take it and you'll feel better right away. And also over the years, most of the patients see worsening of their symptoms, even though the medications didn't change, because I think the mechanical issue or failure worsens over time, and it comes also along with weight gain and the more meals that we eat. So I don't see patients all of a sudden been on medication for a long time and then are able to go off the medication. They usually either require more or they have worsening.
Thank you so much for that. So Jennifer, we're really excited to have you here tonight, I should say now. Tell us a little bit about your story. How long had you been suffering from GERD? What made you make the decision to, see your physicians and decide to have, and I understand you had the CTIF, the combination hiatal hernia repair and the TIF procedure, which we'll ask Dr. B to kind of go more in depth with that. But tell us a little bit more about your story.
Well, I experienced the symptoms for 20 years, and I was on the PPIs for probably the majority of the time. I'm sorry.
No problem.
The side effects were starting to happen. Number one, I had osteoporosis coming on. I was coughing. I was, by the end, I couldn't lean back in a chair like this without having regurgitation of simple water.
Wow.
Very distressing, especially when you're out socializing with friends. I went to my specialist and I talked to him about getting off of the medication. And he was very reluctant to have me go do any type of operational procedure. So I finally convinced him to let me go talk to Dr. Nguyen. And sure enough, I went to see her. We went through all of her tests and we decided to proceed. And I'm really glad I did, because the procedure is not difficult. I also had the hernia, which Dr. B repaired. And, but what the important thing is to tell you is that getting to this point, I realized that I didn't want to suffer anymore. I didn't want to be on medication anymore. And the only way I was going to successfully be off of this is to fix it.
All right.
So I went through the surgery. The surgery was pretty easy. I felt really good the day of the surgery. A couple of days later, I'm starting to feel a little uncomfortable, but Dr. Nguyen gave me perfect instructions. She told me what to eat. She's given me a list of how soon I can transition to additional foods. So prior to the surgery, I went and I created my own diet. And I bought the foods that I could eat. And so therefore, it wasn't a stressful time to transition. And as I'm eating the foods, if I started to have symptoms again, I'd back off. And it would be almost like I'm going back a step, waiting a longer period of time, then I'm moving forward. It was not difficult for me because my goal was to fix my problem. So I didn't want to do anything to jeopardize. So I didn't do any exercising or any physical activity that could damage it. The diet wasn't bad at all. It did take 10 to 11 months before I was symptom free.
Wow.
I have been symptom free since then. So I am really grateful for that. I cannot stress enough how if you just are patient with regaining all of the foods that you want to eat, or all the the choices of foods you want to eat. If you're just patient with all of this, you will experience a normal life. And I've been experiencing that now for months, and I'm very grateful. Very
fantastic. When did you have your procedure, if you don't mind me asking? What was it recently? Or you said you've been 11 months, so you've had it. Was it last year?
I'm over just about a year, okay. Right before COVID in February.
Fantastic.
I had gone in and had it, and yeah, I'm feeling great. I can't stress enough that this is really the answer to your problem.
Have any more regurgitation? Does water come up?
I've only had that one time, and just recently, within the past 2 or 3 weeks. But I contributed it to the food I was eating. The food was a heavy, fatty food. And I just went, I had way too much food. And I deserved what I got. So yeah, you back off of the foods. You learn what you can do and what you can't do. But it isn't a severe back off like what it was prior to the procedure.
Fantastic. Well, thank you for sharing your story. And it's so great to hear that you're doing well, and that you tolerated the procedure well, and also healed, if you will. And I love your story about, being patient and taking the time to heal to get to where you want to be. To live your life normally, unfortunately, after not having GERD. So that's fantastic. So let's talk to Dr. B. We're getting quite a few questions about, the hiatal hernia, the importance of that. Maybe you can discuss, what is a hiatal hernia? How does that relate to your GERD? And fixing that. And then also we had a question about the difference between Nissen and the TIF procedure. So I'll let you go ahead and answer that.
Thanks, Andrea. So just would like to make a point for the audience. The one thing I want the audience to take away today is that GERD is not a disease of too much acid, right? It's not a disease of too strong of an acid or too much acid. And I think a lot of patients out there think that, and that's why they take their PPIs and they feel better. But as Dr. Nguyen alluded to in her first slide, it's really a mechanical problem. And I think a lot of the focus on GERD treatment has been around what can we do to augment or reconstruct that lower esophageal sphincter. But over the last probably 5 years or so, there's really been a lot of science and data showing that the diaphragm, the hiatal hernia component of the anti-reflux barrier is important, if not more important. And so we kind of call this a two-sphincter hypothesis, meaning that there's two valves, at the in that area, one being an external valve, which is the diaphragm, or the hiatal, we call the diaphragmatic hiatus, hence the term hiatal hernia, and the lower esophageal sphincter, what we like to say is the internal valve. And so what a hiatal hernia is when that internal valve, that lower esophageal sphincter, herniates through the hole in the diaphragm. Naturally, there's a hole in the diaphragm for food to pass through, that valve starts to bulge up and down into the chest. And I usually tell patients it's much like a groin hernia. They've either had one or they know someone that had a groin hernia and it bulges up and down. And when they're small, they're often hard to detect because one study will show that it's there and another study by the endoscopist will show that it's 2 centimeters. And as they get bigger, they become more fixed in place. And about 15% of the population will have a hiatal hernia. And if you have a hiatal hernia, you have about a 60 to 80% chance of having reflux disease. So I'm a firm believer that if you have a hiatal hernia, that you really need to do something to repair that. And that's in 2 different areas. That's in we talk about the axial or vertical displacement, so how much that internal valve or LES is herniating up into the chest. But we also talk about the width of the hole in the diaphragm. And so those are very 2 important things for as a surgeon for me to address. And we know that important components of the lower esophageal sphincter are the actual overall length of the LES, as well as it needs to be within an intra-abdominal position where it's subjected to that positive intra-abdominal pressure. And so I think that answered the first question, what a hiatal hernia is.
It did.
The second question was, what's the difference between Nissen and TIF? Was that correct?
Correct. Yes.
Yeah. So the traditional surgical operation is the Nissen fundoplication, and that's where we take the top part of the stomach called the fundus, and we wrap it around that weakened lower esophageal sphincter. Very successful in controlling reflux, but in some instances, or the one way of thinking of it is that procedure. I mean, if you take someone who has a pH study showing abnormal reflux before surgery with a Nissen, they have 0 reflux, right? So they have absolutely no reflux. You're taking someone with abnormally high reflux and really converting them to abnormally low reflux after a surgery. And because of that, patients don't reflux acid or bile or digestive enzymes, but they also can't bring up air. And so difficulty belching or vomiting is very common following the traditional fundoplication. And therefore that can be associated with what we call gas bloat syndrome. We all swallow air when we talk and when we eat, and if you can't belch, right, then that gas and bloating can be problematic following a traditional fundoplication. Now, it's usually temporary, it only lasts a couple months, but if you talk to anyone who's had these problems, in a few small percentage, they can persist out to a year and can be socially embarrassing. So the TIF is, again, the simple difference is it's obviously an endoscopic procedure. It's not a surgical procedure, but it's creating a partial wrap. So not a complete or 360-degree fundoplication. It's creating a 270 or maybe up to 300-degree fundoplication internally. And what it really does is the term's misleading because we're not really wrapping the fundus in the fundoplication. As Dr. Nguyen showed in some of those diagrams, what we're really doing is lengthening that valve, that internal valve, right? So by plicating and invaginating the esophagus into the stomach. So again, as I mentioned earlier, that's one of the important components of that. And the main difference that's been shown out in the studies is as a much favorable side effect profile with the incisionless fundoplication compared to the Nissen.
Perfect. That was great. Thank you so much, Dr. B. We've got a couple of more questions, or quite a few questions that have come up. Some for both of you physicians, and then there's actually some questions for you, Jennifer. So if you don't mind, I'm going to ask some of these questions. This is more of a comment and then a question from James. He said, I just recently had an upper GI and was told everything was okay. I don't understand how there isn't any damage. I asked about the TIF procedure and was basically ignored by the physician. He said it wasn't a proven method. The question is, why would the GI just dismiss this procedure? What are your thoughts?
I think it's not uncommon. I see it in some of my colleagues as well. And I think it's easier to brush aside given a normal study. But what happened is the hernia, the hiatal hernia, is sliding. So anytime you look at it, it may not even be there. So the upper GI may be negative, and the patient may have a hiatal hernia. And also, we talked about the diagnostic test for GERD, and what you haven't had is that pH study to look at to diagnose GERD. So a few more diagnostic tests to kind of further dive into the disease, I think will be more helpful. And I think an upper GI or an esophagogram being normal may not be sufficient if the patient's still having GERD symptoms.
I would just like to comment, because that is the gold standard in diagnosing reflux. And it's very well possible to have significant reflux disease even in the presence of a normal upper GI. The upper GI will give us some assessment of esophageal motility. It may show reflux, so we feel good if there's objective reflux. The radiologist will say, well, we see reflux coming halfway up the esophagus. Well, that's good. That's another piece of the puzzle that fills. But again, what Dr. Nguyen said, you need to have the endoscopy, which most importantly allows us to detect complications of reflux disease before they become symptomatic. So I would not just, again, brush, an upper GI does not in any way rule in or rule out reflux disease.
Yeah, those are both very good points. And I guess kind of the message to this patient is, kind of be your own advocate and go back and ask for additional testing or diagnostic testing to determine, what is really happening there. So thank you. Another question is this question about diet. There's quite a few questions. What's the post-op TIF diet look like? I don't know if Jennifer,
my diet is more strict than Dr. B.
Okay.
So Jennifer's laughing because she knows. So I do 3 to 5 days of clear liquids, which means a lot of bone broth. And the bone broth is really, it has all the nutrients. It keeps patient well hydrated. It has protein, good fat. And then I do about 2 weeks of a thicker liquid. Then it goes to blended saw puree, and then back to normal at 6 weeks. And usually what I do, I'm a little bit more strict because I want weight loss. And I use that as a side effect to the diet. I think weight and GERD really goes hand in hand, and that weight loss, if we can accomplish it, our average is about 20-pound weight loss with our diet post-TIF. And then we try to maintain that weight and not regain. I see that patients who regain the weight down the line, the disease may recur. So that's kind of my fear. So I'm very strict with the diet post-TIF. But Dr. B, what do you do post?
Yeah, to comment that, after any fundoplication, whether it's surgical or endoscopic, you're going to be on a very graduated diet, that it's going to be several weeks before you're eating normally. And I tell my patients that's because the edema, that's created by surgery or by the TIF procedure at that level of the lower esophageal sphincter, and that resolves differently in everybody. I do think the TIF diet is a little bit more regimented, and I think it's just because creating that long valve, so there's more of a surface area to have that edema form. But in either way, patients generally do well. And there is some weight loss, but patients are generally happy with the weight loss when they come back in, and they may, I've even had them say, "Oh, I want to stay on the liquid diet because I'm losing weight." And but generally, it's a little bit of work on the patient after we do the procedure, but in the end, they're very grateful, most of them.
Fantastic. So a few more things on the recovery period is we ask that patients don't swallow pills initially because of that swelling. Dr. B mentioned that pills can get stuck. We ask to limit the amount of weight that we're lifting. So we allow patients to walk around, but we have a 5-pound weight limit so that you're not lifting and injuring the site that we worked on.
Thank you. This question's for you, Jennifer. What were your favorite or the easiest things to eat and drink as you recovered?
I went with clear liquids. I tried my hardest to have hydrating liquids. I even went to some Pedialyte. As I graduated up, I treated myself to some puddings, okay, because that wasn't all day, but it was a treat. Um, Eventually, I ate the cottage cheese, and like I said, I took it very, very slow. Um, uh, the soft fruits that were canned without any skin on them was easy to eat, but that was more toward the end. And I did more conservative. It was a 6-week procedure, if not a little bit longer. Hopefully that answered your question.
It did. It did. Or yes, it did answer her question, Wendy's question. Thank you. This is an interesting from Jas. He's saying, this is what I read from someone's TIF procedure experience. So I could be wrong, but is it true that with a TIF, it is more difficult to detect a hiatal hernia unless an incision is made from inside the stomach?
I'm not sure.
Well, I can just make a broader comment. I think this will answer the question, because I started to allude to it earlier, that there's often a discordance and a difficulty in diagnosing hiatal hernias before any procedure, whether it be traditional fundoplication or TIF. And again, it's because they move up and down. I mean, even Dr. Nguyen and I could do the same endoscopy on a patient. We could measure the hiatal hernia to be different sizes. So that being said, and we often underestimate, as someone who operates on hiatal hernias, the size is almost always larger when we get to the operating room. I would say we're better at estimating the vertical displacement endoscopically as well as radiologically with our esophagograms. Not so good as with the width, but I think we're getting better with that in terms of the hill grade and whatnot. So it's very difficult for us to do that. So I know he mentioned making an incision from inside the stomach. So, that's something we can do. Surgeons have done in the operating room, usually under research protocols. But generally, the goal is to identify the presence of a hiatal hernia. And I think if it exists, it needs to be fixed. And Dr. Nguyen mentioned manometry earlier as part of the evaluation process. And that looks at esophageal pressures. And the studies have actually that have looked at that using manometry inoperatively during hiatal hernia repair, we show that the repair of the hiatus is a significant barrier to reflux. So even more so than what a fundoplication can add. So again, for us, it's just more important to figure out if the patient has one or not, and if they do, that it should be repaired.
Perfect. Yeah, thank you. Did you want to comment, Dr. Nguyen?
Yeah, so I think I understand the question a little bit, but we undercall the hernia and endoscopically because we are treating the condition. So we'll spend a lot more time at the G junction at the time of endoscopy to recreate the hernia, the length and the width of it, to really assess it. And I think the success of the procedure, success with most procedure, is to choose and select the right patient for what we do. And patient selection really is key. So that's the diagnostic part. So for me, after the endoscopy, I really have an idea based on what I see, what is the best approach and the best therapy for the patient based on what we see. So we spend quite a bit of time at the time of endoscopy to recreate what the hernia looks like, because we do undercall.
Perfect. Thank you. Oh, just questions, you guys. But we are getting close to the top of the hour, so I'm going to ask one or two more questions. If we don't get to your question tonight, thank you first of all for asking the questions. We'll do our best to either answer them after the fact. Also, another note I want to say is if you are on and still watching, please comment where you're tuning in from, and you could win our TIF tumbler that we're giving away today. So here's another question, and I think is important. After one has had the TIF procedure, how long will that last? And I know, Dr. Nguyen, at the beginning of your presentation, you kind of showed us some data, but maybe some people jumped on a little bit later. And then in addition to that question was, just jumped away. How long will it last? And then will that come undone some years later, and will I have to get it redone?
Yeah. I guess I'll take that before Dr. B jumps in. But from the studies that are out there, we do have very good 5-year data, so that when we look back endoscopically after TIF, the valve looks the same. The 10-year data is smaller, but that looks at the symptom improvement. So that means if the patients improve, their symptoms will still improve. But I think, I give the story that's similar to joint replacements. You replace your knee, that's not for life. At 10 years, 15 years with use, they're going to need to change the knee out. And so I really encourage the patients to be careful with their diet, be careful with the weight gain, because we want this to last. So we want it to last for a long period. But I always say also that I can always TIF again. And if your hernia recur, we can get Dr. B involved and we can always fix the problem. But I think it'll last longer if we're eating smaller meals. The process, the patient got to where they are because of meals, because of eating, because of gastric distension, and then the hernia, and then shortening of the lower esophageal sphincter. So if we be careful with our diet, we maintain the weight, I think the valve will last longer.
And I'll just comment, the Nissen's been around since the 1950s, and so there's more long-term data looking at that. But generally, the failure rate of a Nissen at 10 years from surgery is about 30%, right? So, meaning 30% of patients will develop some recurrent symptoms. So, granted, the TIF data is not as robust, but the 10-year studies and long-term studies we have do suggest equivalent or not better durability with that. And I will say the number one reason why fundoplications fail, and I can say this for traditional surgical fundoplications, but even more so based on my TIF experience, is a recurrent or undiagnosed or unrecognized hiatal hernia. So, and that's about 80% of failures. And so when we can go back and we can fix the recurrent hiatal hernia, and usually tighten up the fundoplication, whether it's a traditional fundoplication or the TIF, if need be.
Fantastic. Thank you. One last question, and we're going to close up for the night. Will I still need to be on my PPIs after the procedure? And maybe both of you doctors could talk a little bit about that. And then Jennifer, let us know if you're still taking your PPIs.
That's actually our goal of therapy, is not only to improve symptoms with patients who are refractory to the PPI, but the other hope is to be able to get patients off PPI. And the prior slide that we showed, that there is a subset of patients that were able to get off PPI. But, some of the studies looked at either on PPI or off PPI completely, but they actually didn't look at patients who required less of the PPI. So I think overall the results are good in terms of getting patients off PPI.
Fantastic.
Yeah, I would agree. The goal is usually initially within several weeks after any procedures to get them off their PPIs. I think every practitioner is a little bit different, but I personally like to do a pretty quick wean, usually within a week or two following the procedure. So by the time I see them back in the office, 2 to 3 weeks after their procedure, they're completely off PPIs. And so when I ask if they're experiencing any heartburn, I know it's not going to be kind of falsified by them taking their PPIs. So.
Fantastic. Jennifer, are you still taking you're almost a year out. Are you still taking your PPIs?
I am not taking anything. I haven't taken anything since the second week after the procedure. Wow. I haven't even had a single Tums.
Wow.
How good the procedure is. I cannot
Bravo.
tell you how wonderful it's been.
That is fantastic. Well, again, I can't thank you all for being here this evening enough. You guys, all of the explanation, there was tons of questions regarding, TIF and GERD treatment options. Everyone loved to hear, Jennifer, your story. Are there any last tips or advice, Dr. Nguyen or Dr. Bildzukewicz? Did I say it right?
Yes, you did.
See, end of this program, I could say it. Do you guys have any last minute tips or last advice that you'd like to leave to the viewers that are watching?
Felix, you want to go first?
I think, like Andrea, you said it, to be your own advocate. And if this is what you want, like Jennifer, she knew this is what she wanted and she went out and got it because her doctor said there's nothing and TIF is not the answer. Maybe Nissen is the answer, or maybe, I don't know, without looking into it. So be your own advocate and get what you need done.
Fantastic. Dr. Reed?
Comment to the audience, that the GERD is a very treatable condition. People think they have, GERD is, I just have heartburn. Like it's part of just living, like almost like an ingrown toenail or something, it's just another thing they have to deal with. But it is a very serious medical condition. And we didn't talk about this tonight, but if left untreated, it can progress to various complications, some of which can be serious and even precancerous lesions such as bariatric esophagus and esophageal cancer. A significant portion of patients that I see in the office never knew that GERD, if left untreated, could cause cancer, right? So it's a big thing. Esophageal Cancer Awareness Month is coming up in April. So, but like I said, take the initiative. Again, if you're not happy with your provider, maybe it's time to find another provider, get those diagnostic tests, get those referrals. And again, it can be treated very easily with a minimally invasive, either endoscopic or surgical or combined procedure with fairly good outcomes and very, very minimal side effects. So,
well said, both of you. Jennifer, any last words of advice to the people watching?
Be your own advocate. That's the only way you're going to ever be satisfied with your life is to make sure that you beat every bush and you follow up. It's all up to you.
Fantastic. Well, if you are tuning in from Southern California, the Newport-ish, Irvine-ish area, right, Dr. Nguyen, Dr.
Yes.
B? Yes. You can find, and I believe I'm looking at it right now, Dr. Nguyen and Dr. B's clinic information is on the screen as well as their phone number, so you can reach out to them and schedule your initial consults. And if you're not in that area, you can visit GERDhelp.com. We do have a physician finder there, and you'll be able to put in your zip code or your state, and you'll be able to find a TIF trained physician in your area. Again, I can't thank you all enough for being here this evening and taking time to do this TIF Talk. For all of those that are watching, thank you for joining us. And you can catch us every Tuesdays and sometimes Thursdays for our TIF Talks. So you can tune in next Tuesday for our next TIF Talk. Thank you again, and have a very beautiful evening tonight. Thank you so much. Take care.
Thank you.